Would you please raise your right hand, Miss? Do you solemnly swear the testimony you're about to give in the cause now in hearing will be the truth, the whole truth, and nothing but the truth, so help you God? I do. You may be seated.
Good morning, Doctor. There's been a motion to sequester witnesses in the case, so all that means is until all the evidence is over, you can only be in the courtroom when you testify, and you can't talk about your testimony with the other witnesses, or let them talk about theirs with you. Thank you. Ms. McDougall, please.
Good morning, Dr. Casey. If you could move a little closer to that mic and in a loud, clear voice, state your first and last name.
Kelly Casey.
I'm going to ask you to speak up a little bit. Okay, we have the projectors making a little bit of noise. And Dr. Casey, how are you currently employed?
I'm currently the Executive Director of the Brenner Assessment and Consultation Center at William James College.
Like you're shouting.
Okay.
And Dr. Casey, sure, yeah, it might help a little bit, just, and then we can,
Yeah.
Caitlin has to turn it off. Sorry. Dr. Casey, can you briefly describe for the jury, please, your educational background?
I got a Bachelor's of Art degree from the University of Virginia in psychology. I got a master's degree in general psychology at American University and a PhD in clinical psychology at the California School of Professional Psychology in San Diego.
And Doctor, what is you described your current employment. What are your current duties and responsibilities at the Bremer Institute?
I currently supervise predoctoral interns and postdoctoral fellows in psychological assessments and testing cases.
And can you describe for us your professional background before joining the Brenner Center?
I spent 2 years training in adult forensic psychology at Dorothea Dix Hospital in North Carolina. I then moved to Boston to train in juvenile forensic psychology and family psychology at Massachusetts General Hospital. I remained there as a court clinician and then as the director of training in the Suffolk Juvenile Court Clinic. And I was there until 2014 when I moved to the Brenner Center.
And what were your duties and responsibilities when you were at the Juvenile Court Clinic in Suffolk?
I spent most of my time there doing court-ordered evaluations on juveniles and families involved with the court, so either in delinquencies or court family matters like probate matters.
And those were at the direction of the court rather than the direction of either party, would that be fair to say?
Yes.
And do you have any licensure or certifications in the Commonwealth of Massachusetts?
Yes.
What are those?
I'm licensed in psychology, to practice psychology in Massachusetts.
Now, Doctor, you indicated that in your current employment at the Brenner Center, can you just repeat for me what you're supervising?
I'm supervising psychological assessment and testing cases.
And what are psychological assessment and testing cases?
So people who come in and ask for psychological testing to help them determine either what diagnosis fits them, what their educational strengths and weaknesses are, if they meet criteria for a learning disability or other mental health disorder.
And Dr. Casey, in this particular, let me ask you this, you know Dr. Robert Kinshirf, is that correct?
Yes, it is.
And how do you know Dr. Kinshirf?
He was involved in the trial court when I was at the Boston Juvenile Court Clinic, and he now is my boss, basically, at William James College.
And in this particular case, did Dr. Kinshirf enlist you to do any testing of the defendant, Philip Chism?
Yes, he asked that the Brenner Center, and specifically that I do one test for him to help supplement a broader evaluation that he was completing.
And when you went about conducting this one test on the defendant, Philip Chism, were you provided with any other information regarding any opinions that Dr. Kinshirf was contemplating or any other testing that had been done?
No, I was not.
Okay. And what was the test that you were asked to conduct of Philip Chism?
The Rorschach ink blot test.
And what is the Rorschach ink blot test?
It's a performance-based measure of personality and emotional functioning.
And what, if any, training do you have in administering that particular test?
I was trained both in school and as an intern and as a postdoc at MGH.
And what, doctor?
As an intern and as a postdoc at MGH.
Okay.
And I've also attended trainings in the community.
And when did you perform this test on Philip Chism?
In September of this year.
And I'm just going to ask you to keep keeping your voice up.
And I'll just remind the jurors, if at any point you feel like you're missing even a word, just raise your hand. It's very important that you not miss even a word.
Dr. Casey, prior to giving Mr. Chism this test, did you conduct an abbreviated clinical interview?
I did.
And what is the purpose of conducting that interview?
It's my standard practice to give what amounts to a mini mental status exam, just to make sure that the individual is oriented to time, situation, and that they have the verbal skills needed to complete the test. It also allows for the person to get to know me very briefly before beginning the test.
And you conducted such an exam with respect to Mr. Chism, is that correct?
I did.
And did you make any observations, not any statements, but any observations during that period of the testing that were significant to you?
He was open, he was cooperative, he was polite, he was pleasant with me. He didn't appear to be responding to any internal stimuli or acting in any disorganized or bizarre ways. So I felt it was appropriate to go forward with the testing.
And I think we all sort of have a lay understanding of Rorschach testing, but can you tell us exactly how you go about administering, or how you went about administering the Rorschach test to Mr. Chism?
Mm-hmm. He was shown 10 cards, each that have basically an ink blot on them. He was shown them one at a time, and first asked just to hypothesize as to what it might be, what the pictures might represent. Once he'd given his answers, I went back through the cards and made sure I understood where he was seeing it, exactly what he was seeing, and what parts of the blot he was using to form that picture.
And while he's explaining these things, what are you doing to memorialize his answers for your later review?
Writing them down.
Okay. And about how long did it take to administer the Rorschach test?
I believe it took about an hour and a half.
And at some point after that, did you go about the process of interpreting the results and reaching your own conclusions about how he did on the test?
I did.
And can you describe for the jury how you do that?
I used the Exner comprehensive system, which is a standardized system for scoring and interpreting Rorschach results. It has norms for people of all ages, including 16. So I got my series of scores and then compared it to the norms for his age to come up with interpretive statements.
And how do you go about, what is the structure you use in going about analyzing the results of the test?
I generally start with any data that could be important to how a person is thinking and determine if they're showing signs of thought disorder or psychosis.
And in this particular case, did Philip Chism show any signs of a thought disorder or psychosis?
No, he did not.
And what kinds of things, in fact, what interpretation did you have on that part of the test for Philip Chism?
So my interpretation was that a lot of adolescents will see the world slightly differently. They overgeneralize, they make, jump to conclusions, things of that nature. They see the world slightly differently because they're kind of forming their worldview, and as such they can make mistakes in the way they interpret events or read people. I believe that Mr. Chism most likely does that more often than other 16-year-olds, but it did not rise to the level of psychosis or delusional thinking.
And did you reach that opinion to a reasonable degree of psychological certainty?
Based on this test, yes.
And let me ask you about that. Would you ever, standing alone, reach formal opinions as to Mr. Chism from this one instrument?
No, I would not.
Okay. The instrument's always done in conjunction with other testing and other evaluation. Is that fair to say?
Yes, absolutely.
You had a limited role in this particular case?
Yeah, very limited.
Okay. Once you had ruled out a thought disorder or psychosis, what is the next portion of the test that you interpret?
So next I looked, because I did think he thought somewhat differently, I wanted to figure out where areas of weakness might be or reasons why that could contribute to his sort of quirks in his thinking. So at first I looked at his emotional functioning, and it appeared from the data that he was very emotionally constricted. Again, it's not unusual for adolescents to oversimplify problems and kind of avoid emotions that they don't want to deal with. But Mr. Chism, again, seems to do it more than a normal 16-year-old. That does mean that he's less likely to have practice modulating his emotions. It also seemed that at the time of testing, he was quite upset and was experiencing a lot of stress, anxiety, probably some depression.
And this was in September of 2015?
Yes.
Okay. And was there other information that you gained from your testing that you thought was significant to report to Dr. Kinshirf and to report in your report?
Yes. So next, I also looked at the way he sort of deals with other people and what the data of this one test would say about that. And it seemed that he has interest in other people, but he doesn't always understand them very well. So he might misinterpret sort of interactions that he's having with people, their intentions, or the nature of a relationship that he's having. And as I said before, it's not unusual for adolescents to sort of misread social cues and get confused in relationships, but I believe he does it more often than normal 16-year-olds based on this data.
And did you also evaluate the data with respect to how he views fantasy or other, how he views fantasy?
I did. There is not as much data in the Rorschach on that, but there are some variables I looked at, and they suggest that he does have a fantasy life and that he might choose to retreat to that when he's involved in stressful situations or to work out problems in his head before acting on them in real life. But he does seem to understand the difference between reality and fantasy, and he didn't show any signs of getting lost in a fantasy world.
And again, how does that compare to the norms for 16-year-olds that you were looking at?
It was about typical.
Was there anything other that was anything else that was significant to you as based on your training and experience as a psychologist to report to Dr. Kinshirf in terms of this particular test that you administered?
The only other major finding I had was that he seemed to be under extreme stress at this time of testing, and that he was being particularly guarded, anxious, hypervigilant.
In his testing with you?
Yes.
If I could just have one moment, Your Honor.
Sure.
I have nothing further for Dr. Keith. Can you use that phone? Yeah, please. Thank you.
You mentioned norms. What are norms?
So data is collected on a sample of individuals and then averaged across the people to establish what generally is said in response to a given question or item.
So if you're testing a 16-year-old, you want to use tests that are normed for 16-year-olds, correct?
Yes.
And why is that?
Because at different developmental stages, people might answer questions in different ways.
So your test would not have been valid if you did not have norms for 16-year-olds, correct?
Correct.
If you only had norms for adults, that would make the results of your test highly questionable, correct?
Correct.
And that's because adolescents in many ways are different from adults, correct?
They can be.
So the way that psychological tests are normed is by a process that's consistent with scientific thought, correct?
Yes.
And so what happens is the test is given to a broad, let's say a test is normed for adults. A test is given to a broad sample of adults, correct?
Yes.
And that sample includes healthy people, correct?
Yes.
And it can include people that are in the hospital for psychiatric complaints?
Generally, if a test is normed on that, they'll say it's a clinical population rather than a community population, but it can include samples of clinicals.
And if a test is normed for adults, the broad sample would include a broad age group, correct?
Yes.
And that would be important.
Yes.
Now, but this test that you gave was normed, you had a sample of 16-year-olds to compare Philip's results to, correct?
Correct.
And it's that comparison that informs your opinion, correct?
Yes, correct.
And so when you said he was highly depressed, that was because his responses were consistent with 16-year-olds that were highly depressed, correct?
Yes, I said he showed some depressive symptoms.
Pardon me?
Yes, I did say he showed some depressive symptoms
And
at
the
a higher
reason-
level than
And the
others.
reason that you
Hold on,
could...
wait a minute. I'm sorry. Excuse me, Ms. Regan. You were in the middle of that answer?
Right. So he had his scores on some measures of depression were higher than the average 16-year-old.
And the reason that you were able to say that is because his answers were similar to the answers of juveniles who were depressed, correct?
Well, the Rorschach is not normed to say that somebody met criteria for depression, but it is about sort of the way you respond to problems and stress, and the kids who responded in a similar way to Mr. Chism had depressive tendencies.
So now, when you met with Mr. Chism, he was 16, correct?
Correct.
And your test evaluated his mental status at age 16, correct?
Correct.
And it has limited value in thinking about what his mental state was at age 14, correct?
Correct. Anything other than general thought patterns would not be able to be told from one test 2 years later.
Now, you said you showed a series of cards, correct?
Correct.
Can you tell us what we're looking at here?
Sure. Let's take that off the screen first. It's not admitted in evidence or even for ID at this point.
Dr. Casey, I'd ask you to take a look at this. Is this card 1 of the Rorschach test?
Yes, it is.
And is the way the test administered is that you first ask the person that you're testing what it looks like?
Yes.
And they could say this looks like a wolf, or this looks like a cow, or this looks like, I don't know, hip bones, correct?
Yes.
And do you ask any more questions after that?
At that time?
Yes.
No, initially we just get the answers.
So you just go through all the cards like this?
Yes.
Then do you go back through the cards?
Yes.
And what is it you do then?
Then we ask what makes it, we repeat back the answer that the person gave, and then say what makes it look like a cow or a wolf or hip bones.
So, and then they explain their answers further.
Yes.
Now, what is it about the answers that lead you to the score?
I'm sorry, which answers?
Well, there's some way that you quantify what Mr. Chism has told you, what Mr. Chism or any test taker told you, correct?
Right. Yes.
And how do you quantify that?
So initially, the norms or the samples have been created so that hundreds or thousands of individuals are asked the same question. There's then a list of answers that have been given frequently. And next to that list are ordinary, unusual, or minus signs to represent how often those answers will show up in a population that you're using your samples for, so like 16-year-olds here. You can also, if it's an answer that is not listed in the book, you look at the picture and you make a determination as to whether the person is actually using the contours of the blot. So, does it actually look like a wolf or a cow or hip bones? Or could you see why someone might think that it would? Or have they totally disregarded the picture being shown to them in favor of something that they are saying that looks nothing like what they're shown?
And you go through each card like that?
I do.
And then you're going to get, so if we say that it looks like a hippo, if someone says it looks like a hippo, you look to see how common that response is?
Initially, I would look to see how common it was, if it was included in the list of answers that have shown up commonly amongst people that were sampled.
And does it go further where you can actually say people who see the hippo are depressed?
No, it wouldn't be that direct.
How do you get to depression?
Okay, so after we decide what the form quality is, whether it's unusual, whether it's ordinary, whether it's a minus response, then we're looking at what parts of the blot did they use, and in what ways did they use it, what location. Was it the whole? Was it part of it? Did they use colors? Did they not? Was it form only? Variables of that nature. So what parts of the blot did they use and how did they use it? Did they use it well? There are over 100 different variables that then get scored based on the way they've used the blots over all 10 blots. So we would get sort of a score for his use of color across all 50 of his answers rather than specifically related to any one answer he gave.
But as it relates to Ms. Regan's question, it's not that, as I understand she's asking, it's not testing for depression. You look at the answers and see whether other people who have given those answers also indicate some sort of depression.
Right. So of all those...
I think that's the question.
Okay. Of all those variables, there's a constellation that if a number of things are also elevated at once, there is a index for depression, and that will either be positive or not. And his was positive.
And you did recommend that Mr. Chism be monitored for suicidal behavior, correct?
Yes.
And that was given his problems with depression, correct?
Depression, impulsivity, the stress of the situation.
And feelings of helplessness.
Correct.
Now, you also concluded that at times, however, his reality testing seems to be impaired more by unusual perceptions, correct?
Correct.
And you qualified that as those found in individuals with affective and more likely found by individuals with affective or personality disorders than psychotic thought process, correct?
Correct.
So you made a distinction, correct?
Correct.
So his reality testing was impaired, correct?
Yes, there were signs that it was.
But based on what he saw in the ink blots, you concluded that impairment was not psychotic, correct?
Correct.
But that it was impaired.
Yes.
I have no further questions.
Just on that last point, Dr. Casey, but he could distinguish reality from fantasy, is that correct?
Yes.
Okay. And you didn't find any disorganization in his thought at all, did you?
None.
Any recrosses for you?
Do you solemnly swear the testimony you're about to give in the cause now and hearing shall be the truth, the whole truth, and nothing but the truth to help you God?
I do.
You may be seated.
Good morning, Doctor.
Good morning.
There's been a motion to sequester witnesses in the case. All that means is until all the evidence is over, you can only be in the courtroom when you're testifying. You can't talk about your testimony. We have the other witnesses, I'll let them talk about theirs with you. Thank you.
Good morning, Dr. Hebben. Can you please state your first and last name?
My name is Nancy Hebben.
Can you spell your last name, ma'am?
H-E-B-B, like in boy, E-N.
Dr. Hebben, can you tell us, please, what your current employment is?
I am employed in my own private practice at this point in time.
And Dr. Hebben, can you describe for us your educational background?
I got my PhD in 1979 from Wayne State University in Detroit. I did my internship here in the Boston area at the Boston VA. From there, I went to the Massachusetts Institute of Technology, where I did a National Research Service Award for 3 years as a postdoctoral fellowship and specialized further within the area of neuropsychology. Following that, I went to the McLean Hospital, where I was chief consulting neuropsychologist from 1982 to 1998, after which I went into private practice.
And what are your current certifications or licensure that you hold anywhere?
Well, I've been licensed as a psychologist, a health service provider in the Commonwealth since 1980. I was also licensed, but I've put that on an active status in Oklahoma as a psychologist. I'm also board certified in clinical neuropsychology from the American Board of Professional Psychology. I think that's been for 21 years or something like that at this point.
And Dr. Hebben, are you on any editorial board?
I do ad hoc reviews for journals like the Journal of Clinical Neuropsychology or related journals in my field.
And are you a member of any professional practice activities?
You mean like membership organizations?
Yes, sorry, the back
yes.
question.
So I'm a member of the American Psychological Association and Division 40 of that organization, which is specifically for neuropsychology. I'm a member of the National Academy of Neuropsychology. I am a member of the International Neuropsychological Society. I'm also a member of the American Academy of Clinical Neuropsychology. I'm on that I'm on the board of directors of that academy.
And do you have any teaching responsibilities?
I do.
What have those been?
Since I think it's 1985, I have taught in the extension school at Harvard University. I also have teaching responsibilities as part of my appointment at Harvard Medical School. They've changed the title recently, so let's see if I can get this right. Assistant Professor of Psychology in the Department of Psychiatry part-time at Harvard Medical School.
And Dr. you talked a little bit about the work you did at McLean Hospital for 15 years, is that correct?
16, I believe.
Okay.
I'm still an associate at McLean Hospital. I just do not practice there full-time.
In what type of facility is McLean Hospital?
It's a private psychiatric hospital in the partner system. It's affiliated with Harvard Medical School, MGH.
Where is McLean located?
It's in Belmont, Massachusetts.
And what were your duties when you were I think you said, director of neuropsychology at McLean?
I was chief consulting neuropsychologist, which meant that I ran the neuropsychology department. I did assessments of children, adolescents, and adults in neuropsychology. I supervised postdocs and interns who were also learning in the field. I did the administrative work. I assigned cases. I did feedback sessions, consulted with the psychiatrists and other professionals on staff at McLean.
What is this may not be the most relevant question, but what is the level of care provided at McLean? How ill are some of the patients?
Well, at the time that I was there, things have changed. Back in those days, it was common for people to come in, generally for pretty severe problems, which they couldn't handle on their own. And while I was there, it changed such that because we were no longer, we being the entire country, were no longer housing people in psychiatric facilities. It became such that people were generally even more severely, acutely ill and would have to come into hospital to control their illness.
Some of the patients that you evaluated and treated at McLean Hospital, were they experiencing acute psychosis?
Absolutely.
Okay. And you've talked, can you just explain to us what the field of neuropsychology is?
Neuropsychology, generally a neuropsychologist is clinical psychologist, which is what I am. My degree is in clinical neuropsychology. I've specialized in neuropsychology beginning in graduate school. But what we do is use psychological and neuropsychological measures to try to objectify brain illness, psychiatric illness. We also look at just sort of cognitive strengths and weaknesses. We attempt to understand someone's cognitive profile in order to be able to assess if their behavior is indicative of some sort of cognitive illness or psychiatric illness.
And in fact, the types of instruments or tests that you use, do they fall roughly into two categories in terms of what they test? Meaning cognition and behavior.
I would say that we're looking, we have tests that help us measure cognition, help us measure personality, help us measure emotion. And when we're putting together a battery of tests, we're going to try to address all of those issues as they are relevant.
Is there any distinction in those three areas of testing as to whether you would expect results to change in a patient depending on the point in time at which the test is being given?
Well, we might expect change if someone has suffered some sort of neurologic accident, a stroke, for example, or they've had a brain injury. You might expect change if someone was floridly psychotic, although you wouldn't test someone who was floridly psychotic at the time. Sometimes we're just looking to see developmental patterns that, there hasn't been any change at all. This is just the way the person's brain developed, and we're measuring their behavior to try to get back at figuring out what is it about their brain.
Dr. Hebben, in this particular test, were you retained at the request of Dr. Robert Kinshirf to conduct a neuropsychological evaluation of Philip Chism?
Yes, it's neuropsychological and psychological evaluation.
Okay. And whose decision was it to decide what instruments or what tests to use?
It was ultimately my decision based on my consultation with Dr. Kinshirf in trying to figure out what is it he was looking for. And so I could, based on what he was looking for in terms of did he want me to help him with diagnosis? Did he want me to help him with determining if Mr. Chism had some sort of cognitive defect? Did he want me to help him assess whether or not Mr. Chism was malingering or feigning mental illness? So he told me what he was looking for. I put together a battery of tests that would allow me to answer the questions.
Had you ever worked with Dr. Kinshirf before this particular case?
I had not.
And were there any sources that you reviewed in assisting you in determining what testing to do?
Yes, my education, training, and background, my 30-year-plus history as a neuropsychologist and psychologist, but I also consulted in particular texts on looking at feigning of mental illness in children and adolescents.
Was there any challenge posed to you in designing a battery of tests given Mr. Chism's age at the time you were testing him of 16?
For some instruments, yes, there was.
And why is that?
Well, because most of neuropsychologists and psychologists use tests that are called performance validity tests and symptom validity tests to help us to understand if we can trust the information that we're obtaining from an individual. It's very easy to feign cognitive disability, to feign mental illness. It's an easy thing to do, and one cannot know that that's happening simply by looking at someone. We can't observe that. If someone's not putting their full effort into testing, we don't know that. If someone just simply says to us, after we give them a memory test, oh, I can't remember that, we can't know that they really can't remember that. So we have tests that we use that we call performance validity tests and symptom validity tests that help us establish whether or not the data that we're obtaining is reliable and valid. So a performance validity test is specific for cognitive deficits. So these are tests that look like real neuropsychological tests, but indeed are very, very simple and easy to do. And they've been validated against populations of people with documented severe brain disease. And we've established that those individuals can pass these tests. So when we give a test like that to someone else, and they fail that test, that helps us to know whether or not we can trust the data that we've obtained as being an accurate representation of their true cognitive ability at that time. Symptom validity tests help us understand whether or not we can trust that the person is accurately reporting their symptoms. Whether they're having hallucinations, whether they are depressed, whether they are having somatic or body complaints. So these are instruments that allow us to look at the accuracy of symptom report. And again, those are developed by administering them to people with genuine difficulties. And if someone reports over and above what people with genuine difficulties report, or they report things that are different from the kinds of symptoms that someone with a genuine psychological illness, for example, reports, then we can at least understand that we may not be getting an accurate picture of their true problems at that time.
Now, did you have occasion to meet with Philip Chism when you were administering the first of your testing?
I did meet with Mr. Chism, yes.
And without going into anything that was said, do you conduct any sort of an interview or an assessment prior to administering any testing?
Oh, you'll always conduct an interview because you need to get the background data. Test results are of usually no benefit if you don't have a history or a context into which to put those test results.
And in fact, in addition to interviewing Mr. Chism, did you review any records of his prior to conducting your testing? I
did.
What kinds of records did you review?
His school records and a report of a psychiatrist.
And when you met with Mr. Chism, did you have an opportunity to make any observations of his demeanor when you were meeting with him?
Yes, as part of an assessment, you're going to observe how a person behaves during that assessment. Are they cooperative? Is there evidence that they're hearing voices? Are they paying attention to what you're doing? Are they hostile? You're going to be looking for all sorts of things because, again, we need to be able to know are the results that I'm getting, are they valid?
And when you were making that observation or assessment of Mr. Chism's demeanor, did you have any concerns about going on with your testing?
I did not have any concerns about proceeding with the testing.
Now, Doctor, I want to direct you to a particular test, the MMP1A. Was that one of the tests that you conducted on Philip Chism?
Yes, that's actually the Minnesota Multiphasic Personality Inventory, it's the MMPI, and I used the adolescent version.
Dr. Hebben, when you say this is the adolescent version, what ages are considered adolescents from your perspective as a psychologist?
Oh, it's not from my perspective, it's from the perspective of the test developers, and this test was developed specifically for adolescent ages. That is, there is an MMPI that you would give to an adult, and this was a version of the MMPI that was extended downward, I believe, to age 14.
And what is the purpose of administering the MMPI?
The MMPI is it's called a personality inventory, but what it really does is allow us to look at the kinds of clinical symptoms someone has and then to use that objective report and compare the individual to people with documented psychiatric illness to see the profile that someone obtains on the MMPI, which diagnostic group does it appear most similar to. The advantage of the MMPI is that it also contains embedded in it symptom validity measures. So before you even look to the clinical scales to see is the person reporting a pattern consistent with depression, or are they reporting a pattern consistent with a psychotic disorder, you have to first look to see is the test valid as a measure of their true psychopathology, if they have it at that point. And so you look to see is the person underreporting? That is, are they trying to present themselves as being particularly virtuous? And you can see that from people. So, for example, you could imagine that if someone were in a custody battle for their child and they had to undergo testing, they might want to try to present the very best picture that they could and deny all kinds of psychopathology because they want to have their child in the custody battle. Or if someone is applying for a job, it's not uncommon in some fields like police police work and so on, that the individuals will have to take the MMPI. And so, again, they want to look particularly good. At the same time, there are scales that allow you to look if someone is exaggerating psychopathology, and that occurs as well. In criminal cases, for example, someone who wants to avoid criminal responsibility might exaggerate their problems in order to look as though they have some severe mental illness. And so you first look at those scales. If those scales reveal that this is a valid profile, then you can go forward and look at the clinical scales to see, okay, what diagnostic group is this person most like?
And how is the MMPI administered? What does the defendant actually have to do?
Well, you can do it paper and pencil so that a person is given a booklet with questions, and then they have a bubble sheet in which they say true or false for each statement. I actually do it with the computer because each statement appears one at a time, and a person just inputs their answer, T for true or F for false for each statement.
And how do you then go about scoring or interpreting the results of the MMPI? How did you in this case?
Well, you simply allow the computer to generate the interpretive report. So this is not my subjective interpretation of this data. This is the data as compared to the diagnostic groups, and it's a report that's generated from the test author.
And Dr. Hebben, what were the results of Philip Chism's MMPI for adolescents?
The results suggested that it was likely invalid because his F-K scale was excessively elevated and suggested that he was attempting to fake bad and to demonstrate that he was severely mentally ill.
He was attempting to demonstrate that he was severely mentally ill. Is that correct?
Correct.
And because he was invalid, you couldn't even go on to interpret the other data as to whether it reflected any mental illness. Is that correct?
Right, because you don't know. When someone is feigning mental illness or exaggerating mental illness, it's as though they are painting the window which you're trying to look through, painting it. And so you can see maybe that there's something moving behind there, but you just don't know what it is. You can't know how much of it is real or if any of it is real.
This might be a time for the break, Your Honor.
Okay, ladies and gentlemen, we're going to take, of course, got to remain in session to address an issue of law. What we're going to have you do is step out. I'm not sure how long it'll take, but we'll move along as efficiently and fairly as we could. Don't discuss the case among yourselves with anybody else. First thing I'll do when you come back into court is to make sure you follow those instructions.
All right.
Dr. Hebben, in addition to the MMPIA, did you conduct a test, the acronym for which is the BASC-2?
I did.
And what does the BASC-2 stand for?
The BASC-2, it stands for the Behavior Assessment System for Children. It's the second edition. That's what the 2 stands for. I gave the self-report of personality measure appropriate for Mr. Chism's age.
And what is the BASC-2 intended to test or to measure?
It is another inventory that's designed to help objectify self-report of symptoms and to see if various aspects of a person's functioning, if areas are compromised, what areas are compromised, according to this individual self-report.
And how is the BASC-2 administered? Is it also true, false, multiple choice? How does it work?
I believe it actually it allows you to answer questions according to a scale from not at all to a little, somewhat, and often. Although I believe there are also some questions that are true, or statements that are true, false.
What were the results of the BASC-2 as administered to Philip Chism?
Well, like the MMPI, the BASC-2 has also validity scales, so you can look at whether or not someone is answering consistently or perhaps just responding randomly, which again would invalidate the results that you get. And you can look at whether or not someone is exaggerating or faking bad, as it's called. And the results from Mr. Chism's were indeed that he was showing what was thought to be excessive negativity and a fake bad profile.
Malingering.
I don't think that from the BAS you can say necessarily that it's malingering. It's consistent with malingering. Faking bad is someone who is certainly exaggerating their problems.
Now, in addition to those two, once having completed those two instruments and having gotten the results that you got, what analysis did you do to determine whether you would do other testing?
Well, based on, actually at that point in time, these are scored after the fact, and they're scored by the computer. It's a standard interpretation that's done, interpretive reports. I included the symptom validity measure, 2 symptom validity measures, the structured inventory of reported symptoms, which is exactly what it says it is. It's an inventory that it's structured in the way you ask the questions, the particular questions that are asked, and then and it is specifically designed to look at whether or not someone is feigning mental illness. And I also administered the Miller forensic assessment of symptoms, I think it is, the MFAST. Which is a similar thing. It's more of a screening measure than the SEERS is. SEERS is a very in-depth one that you actually do as an interview, a structured interview. The MFAST, a person has the questions in front of them and indicates their answers on a sheet.
And with respect to the SEERS and the MFAST, did you do any, did you take into consideration the defendant's age at the time you were testing him before deciding to perform those 2 particular tests?
I did.
And starting with the SEERS, can you explain to the jury what considerations you needed to take into account in giving the SEERS to an individual, the defendant's age at the time you were testing him in September?
When the SEERS was designed, it was designed for individuals 18 years and up. And so technically, Mr. Chism didn't fall into that group. So I consulted with Richard Rogers' textbook on assessing deception, in specific the chapter assessing deception in children and adolescents, and made sure that there were in fact norms, but that the test had been validated downward to age 14, so that I could feel confident in using it in collaboration with other instruments to look for converging validity.
I'm just going to stop you for 1 second. What is the significance of Richard Rogers' textbook with respect to the SEERS test in particular?
Well, he actually developed the SEERS. He did not write that chapter. It's an edited book, but Richard Rogers is the author of the SEERS.
And when you just use the term convergent validity, can you explain to the jury what you mean by that term and what you're looking for?
What I'm looking for is, are all the test results coming in the same direction? What I want to do is to reduce the risk of obtaining a false positive. I don't want one marker or one test that says someone is feigning mental illness and then go from there and say, oh, well, I know that this person is feigning mental illness. I want multiple measures that point in the same direction before I'm willing to make to draw such a conclusion.
And in fact, did you give the defendant the SEERS after establishing that it had been validated down to 14?
Yes.
And what were the results of the SEERS for the defendant, Philip Chism?
On the SEERS, I just need to refresh my memory. He had one, the SEERS is arranged so that you can look at definite, malingering versus probable malingering versus indeterminate, you just can't know, versus normal or honest responding. And I believe he had only one score in the honest range out of multiple scores. Most scores were in the indeterminate range, and one score was 1 point away from definite malingering.
So now you've done 3 instruments, is that correct at this point?
Correct.
Did you, I think you referred to the MFAST. Did you, at that point, consider the MFAST for Mr. Chism?
I had considered I had brought along the MFAST with my test materials.
And once again, with respect to the MFAST, did you have any concerns with administering the MFAST to someone of the defendant's age in September of 2015?
Well, at the MFAST, like many of our tests for both performance validity and symptom validity, with the exception of when you have a test that has embedded validity measures like the MMPI and the BASC. Most of these standalone measures of performance validity and symptom validity have been initially validated in adult populations. And so what I want, and that was true of the MFAST 18 and above. And so I did some research to find how close could I get to an individual who was 16 years, 6 months old, and indeed found that there was evidence that it had been used in individuals as young as 17.
And at that point, did you make a determination to use the MFAST with the defendant?
I did, yes.
And how does the MFAST work?
The MFAST is simply a series of statements, questions that, like the Sears, are things that are rarely seen in true psychopathology, or are combinations of things that are rarely seen. And so a person either says, yes, that affects me, or no, it does not. And then ultimately that's all put together. You never take anything from one question alone. It's the questions taken all together from which an interpretation of a test is drawn.
And what were your conclusions with respect to Mr. Chism and the MFAST test?
On the MFAST, he achieved a score that had a positive predictive accuracy of 100% for feigning mental illness. I believe the score for a clinical population, that is individuals who have true mental illness, documented mental illness, would be unlikely to get a score, I believe the cutoff is 10, and his score was 16.
Now, in addition to the 4 tests you've already described for us, did you do any other testing of Mr. Chism that informed your ultimate conclusions that you provided to Dr. Kincher?
I did additional testing, but because of the evidence of likely exaggeration or outright feigning of mental illness, I couldn't rely on those results because they were things like measurement of depression, anxiety, and so on. And I did not know how much of his self-report was accurate. So I gave what's called the Beck Youth Inventories, which looks at anxiety, depression, self-esteem, anger, and disruptive behavior. And
I'm sorry, what was the last thing?
Disruptive behavior. And he had significant elevation on the anger scale, a lesser but also extreme elevation on the disruptive behavior scale, and a milder elevation on the depression scale.
Doctor, let me ask you this. With respect to all of the testing you did, would you administer those tests to someone that you had concluded was experiencing psychosis?
If someone were floridly psychotic, I wouldn't test them at all because I wouldn't know if I was getting their true performance when they're in a state of mind where they're more connected with reality.
And based on the time you spent with Mr. Chism and based on your observations, did you reach a conclusion as to whether he was floridly psychotic in September of 2015?
I did.
What was that opinion?
Based on my observations and other information that I gathered, I did not believe that he was actively psychotic at the time that I was assessing him.
And Dr. Hebben, based on all of the testing that you personally did and your results, did you reach an opinion to a reasonable degree of psychological certainty as to the results of your testing? Sort of, did you reach, let me ask you this, did you reach an opinion to a reasonable degree of psychological certainty to convergent validity?
I did.
And what was that opinion?
My opinion was that his report across these various measures revealed multiple inconsistencies, and that, taken together with his history and his presentation to me, were highly suggestive of a malingered mental illness.
And Doctor, you certainly, even in a finding of malingered mental illness, cannot rule out that there's also mental illness at play, can you?
That's true. Malingering really can sort of come at three levels. You can have what's called pure malingering, and that is a person who is outright faking a mental illness. You can have partial malingering in that a person does have mental illness and they're simply exaggerating the symptoms. And you can have a sort of misattribution malingering, that is a person has symptoms of mental illness and is consciously attributing them to what they know to be a false source of the problem.
Now, doctor, after you had reached your conclusions independently based on your own testing, did you have an opportunity to review testing that had been done prior to your involvement, or the raw data for that testing?
I did.
And were there any particular testing that was significant to you in either undermining or corroborating your own conclusions?
Yes.
What was that?
The testing that was most important in terms of the issue of malingering was the intellectual testing that had been done first in March of 2014, and then a second attempt to measure intellect in June of 2015.
And can you just explain to the jury, based on your training, are these intellectual tests that you typically would use in your practice with individuals other than Mr. Chism?
Well, I actually would have done intellectual testing of Mr. Chism, but my review of all the school records and so on indicated that there was absolutely no reason to suspect that he had a cognitive defect that could have impacted his behavior in this circumstance. So I was aware that he had been given an intellectual.
It depends on where your the objection is starting.
Right now.
None from this point on?
Yes.
Okay, the objection is sustained.
Did you have an opportunity to review the raw data from the intellectual testing done in March of 2014 and June of 2015?
I did.
And was your interpretation of that raw data significant to you?
It was.
What was significant about it?
Objection.
Okay. I will see counsel at the sidebar, please. So a few times during the trial, I've given you limiting instruction. Limiting instructions really do require you to compartmentalize your mind and be disciplined and consider the evidence only for the purpose for which it's being admitted and for no other purpose. And so as it relates to the direct testimony that you're hearing, this evidence may be considered by you as it relates to issues and contentions of allegedly faking bad, exaggerating problems, or malingering or convergent validity, and it may not be considered for any other reason.
Dr. Hebben, without going into the details of the testing, prior testing you reviewed, did anything in the prior testing you reviewed undermine your conclusions that you've already testified to?
Nothing at all.
And in fact, is there something called a practice effect?
Yes, there is.
So before I ask the next question, can you explain what a practice effect is?
Well, in testing, having taken a test can prepare you and prep you for taking that test in the future. So we have to be concerned with any testing that has already taken place and take that into consideration in developing test batteries that we're going to use in someone who's already been tested and in what particular tests we're going to do. And if we do repeat a test, taking into consideration practice effects in our interpretation of the results.
So going into your testing, did you know what testing had already been done but not the raw data or results of that testing?
That's correct.
And it was only after you had completed your testing and reached your own conclusions that you had an opportunity to review the raw data?
It was only after I'd completed my testing. I had the raw data before I wrote my report. However, I did not use that raw data in the development of my opinion. My opinion is based solely on the data that I personally collected.
I have nothing further for Dr. Hebben at this time.
Okay, Ms. Regan, are you able to inquire in other areas?
Yep.
Okay, when you've exhausted that, if you could let me know so I can see you at the sidebar, please.
Yes.
Thank you.
Good afternoon, Dr. Hebben.
Good afternoon.
Now, you met with Philip Chism once, correct?
Correct.
And you met with him on August 17th, 2015, correct?
That sounds correct, yes.
And you met with him from 11:30 to 2:30, correct?
That sounds right, yes.
And during that time, there was no break, correct?
That's correct, no break.
Now, and you gave him tests that had a lot of questions, correct?
Yes, there are some of the questions. The MMPI, for example, has quite a few questions.
So the MMPI has 470 questions, is that right?
I can, I don't have no way of checking, but that maybe I do. Wait a second, hold on.
I think that you have the answer sheet.
Yes, that's exactly what I was thinking. I might have the answer sheet. 470.
And the SRP, part of the BASC, has 137.
Is that it? I thought it was a few more than that. I thought it was like
Can you check how many?
thought maybe it was 170 something. I have 176.
Okay. And the Sears has about 156?
That sounds about right, yeah.
And the MFAS has 25?
Correct.
So it was about 900 questions all totaled?
I didn't do the math just now, but if
Quite a few.
you would stipulate that, yeah.
Now, you found that Philip Chism was malingering, correct?
My opinion is that the test data indicate that there's a very likely possibility, or it's very likely that Philip Chism was malingering mental illness.
And what you mean is exaggerating his symptoms, correct?
Well, I can't know if it's simply exaggeration or if it's it's that more pure malingering that I talked about.
So Philip Chism, there are a couple possibilities then. Philip Chism could have no psychiatric symptoms at all and just be exaggerating all his symptoms, correct?
Well, he could be creating symptoms
all
in
his
that
symptoms.
circumstance, yes.
So Philip Chism could have no mental health symptoms at all, and he could be creating out of whole cloth his symptoms.
Yes, that would be pure malingering.
Or Philip Chism could have mental health symptoms and be exaggerating those symptoms, correct?
That's correct. That's partial malingering.
Or Philip Chism could have mental health symptoms and not endorse those symptoms on the test, but endorse others that he doesn't have, correct?
I'm not sure how to answer that question. How would I have any way of knowing if he's choosing to? The questions aren't separate, so that yes, certain items fall into certain categories and go different ways, but there's a lot of overlap in those, so that if he's reporting symptoms, he's likely reporting, if this is partial malingering, he's likely reporting both symptoms he does have as well as symptoms he does not, or which he is exaggerating.
And he also may be claiming symptoms, that he has symptoms currently that he doesn't have currently, correct?
If you mean by that, could this be pure malingering? I think I already answered that. Yes, it could be pure malingering.
But the problem with malingering, or finding malingering, is that you don't know what's behind it, correct?
What is behind what?
I could have a moment.
Sure.
The presence of malingering does not rule out the possibility that Philip Chism has a mental illness, correct?
Correct. That's the partial malingering that I was talking about. I can't know from his report whether it was pure malingering or partial malingering.
And the results from his evaluation, what they just tell you is his self-report via your test was unreliable.
No, they don't show that it's unreliable. In fact, the convergence across the 4 tests indicate that it was indeed very reliable. What it tells us is that we can't know accurately if he does have a mental illness and what that mental illness is.
But didn't you write in your report, the results from this evaluation indicate his self-report is unreliable?
Could you direct me to where it is so I can be sure?
Page 19, second to last paragraph, last sentence.
Okay, so the test results are not unreliable, but we can't trust that Mr. Chism is reliably reporting.
Mr. Chism's answers aren't reliable, right?
No. Mr. Chism's approach is inconsistent enough with his reported behavior is inconsistent enough with his observed behavior, and his reported behavior is inconsistent enough, and that's the meaning of reliability, inconsistent, is inconsistent enough with the test findings that we cannot take the test findings as a valid representation of whether or not there is a mental illness underlying this.
I'm going to read you a sentence, and you tell me if you agree with it. The presence of malingering does not rule out the possibility Philip Chism is experiencing some kind of psychopathology, but the results from this evaluation indicate his self-report is unreliable and makes accurate diagnosis difficult.
That's
Correct?
exactly what I was just explaining, which is his self-report is inconsistent with his observed behavior. His self-report is inconsistent with the test results, meaning that his self-report is unreliable, and therefore we cannot take his self-report as valid representations or valid indications of whether or not he has a mental illness or he has a mental illness and he's simply exaggerating it.
Now, I'm going to just read that sentence again.
Objection.
Well, I'm going to allow it because I think that that the answer goes beyond the question, and therefore may be lost for the purpose for which it's being offered.
If I could just ask them that the entire sentence, which was just read but was not read the first two times, be read.
Under the doctrine of completeness, if that doesn't happen, the doctrine of completeness under 106 is a rule of interruption. If Ms. Regan doesn't do it, you can stand up and do it immediately.
Right. True or false? I'm reading a sentence you wrote in your report. The presence of malingering does not rule out the possibility Philip is experiencing some type of psychopathology, but the results from this evaluation indicate his self-report is unreliable and makes accurate diagnosis difficult. True?
Yes, that is what I wrote in my report. Philip Chism's report did not reliably convey whether or not he has a mental illness or is exaggerating a mental illness.
So, have you been trained not to answer a question yes or no on cross-examination?
Objection.
If the answer goes beyond the question and you have a motion to strike, I'll certainly consider it, Ms. Regan.
What was the referral question from Dr. Kinshirf?
Dr. Kinshirf asked that I do whatever evaluation was appropriate for aiding him in his putting together all of the history, all of the records, all of the data, with all of the test results, with his interviews, to come to a diagnosis for Mr. Chism if he was able to do so. So my task was to do whatever tests would be necessary to answer questions about diagnosis for Mr. Chism.
So, you picked the tests.
That's correct.
And you gave 1, 2, 3, 4, 5, 6, 7 tests, correct?
Yes.
Now, one was a test of memory malingering, correct?
Correct.
And he was not shown to be a he was not shown to be, he was shown to be reliable on that test, correct?
On that particular test, he scored normally.
And on the dot counting test, he scored normal.
Correct.
No sign of malingering there. On those particular tests, just limiting you to these tests.
I understand, but I was going to try to answer the question. The dot counting test and the test of memory malingering, despite its name, is not a direct test of malingering. It's not a symptom validity test, it's a performance validity test. And what it looks at is whether or not someone scores normally, and then you can assume that any cognitive tests that you've given are representative of a person's cognitive ability. positive score, for example, in the direction of poor effort, for example, on the dot counting test, would lead you to the conclusion that, I need to investigate this more, and the person is giving poor effort, but it doesn't necessarily lead you to a conclusion that someone is malingering, not in the way that the symptom validity tests like the Sears and the MFAS do.
But it's a test of a certain kind of faking, correct?
It's really considered a test of effort. One of the things that can happen in neuropsychological testing is that we're dependent on the person to be doing their best, but not everybody does their best. And we can't see suboptimal effort unless a person just absolutely refuses to be tested. Well, we can't see if someone's not doing their best. So we have tests like the dot counting test that allow us to evaluate whether or not someone is working effortfully in the test, and therefore allow us some confidence that the results we're obtaining are accurate and reliable representations of their cognitive ability. The dot counting test is not a symptom validity test. It's a performance validity test. It's looking at another issue.
So Philip was trying on these tests.
Philip was. The other thing about performance validity tests is you can take something from a negative result, but you can't be certain with a positive result. In other words, if someone shows evidence of poor effort or fails a performance validity test, then you can go forward and say, I can't be confident that these tests represent, on the neuropsychological tests, that they represent anything more than the minimum of someone is capable of. If someone scores normally on performance validity tests, you can't. It doesn't go in that direction. I mean, you're going to go forward and interpret the test results, but all you can say is that it appeared that they were giving full effort on those particular tests.
So he doesn't win with those.
Well, I didn't give him cognitive measures. So, I mean, he wins in the sense that he scored normally on the dot counting test and the TOM, but those, again, are performance validity tests, and they're about cognitive ability. They're not symptom validity tests about psychopathology.
But again, if he had scored abnormal on those, it would be a sign that he wasn't trying, correct?
That's correct. If he had scored abnormally on those, it would be an indication that were I to have given him cognitive ability tests or cognitive tests, that I couldn't be certain I was capturing his full potential.
And if he had scored abnormal on those, that could show a different type of him skewing tests, correct?
That's correct. They could. You can't. If from a failure on a performance validity test, you can't immediately jump to the issue of malingering, but there are some performances on those kinds of tests that would lead you to the conclusion that someone were malingering. For example, if someone on a test were to score below chance, that cannot happen by chance alone. And so if someone scores below chance on one of these measures, then you know that at least on some of the items, they purposely chose the wrong response, and that in and of itself is malingering. So you can go to the issue of malingering, but they're not tests of malingering in the same way that the Sears and the MFAS are tests of malingering.
Anything else you want to say?
Objection.
Again, as far as the issue that you're addressing with that last question, Ms. Regan, if there's a motion to strike, for instance, from the plaintiff, for example, I would entertain it. If you want to repeat the question, if you get a non-responsive answer, you can do that. Sure.
The MFAST is a test for malingering, correct?
Correct.
The SEERS, Structured Inventory of Reported Symptoms, is a test for malingering, correct?
Correct.
The MMPIA has a portion that looks at malingering, correct?
Yes.
So, and then you gave two other tests. The self-report of personality, correct?
The BASC, too, yes.
And the Beck Youth Inventory, too, correct?
Correct.
So, you gave, we'd already established you gave 7 tests, right?
Correct.
And 5 of them looked, at least in some part, at malingering, correct?
5 of them could be used in the direction of assessing for malingering, although they're not all direct measures of malingering.
Is the MFAST a direct measure of malingering?
Yes.
Is the SEERS a direct measure of malingering?
Yes.
Is the test of memory malingering a direct test of the issue of effort?
Yes.
Is the dot counting test a direct test of the issue of effort?
Yes.
Now, a manual for a test is an important tool, correct?
Yes.
And a manual ensures that the test is given consistently so that scoring can be as accurate as possible?
Manuals are developed so that it instructs the person who's using the test how to score, how to administer, score, and interpret the test.
Manuals ensure that a test is given consistently so that scoring is as accurate as possible, correct?
Well, I'm struggling with the word ensures because the manual itself can't ensure. The manual sets forward those things with the idea that a psychologist or whoever using the test will then give the test in the proper way.
One of the purposes of a manual is to ensure the test is given consistently so scoring is as accurate as possible.
Again, I have trouble with how a manual can ensure anything, but the point of a manual is to set out all the parameters for a standard test, a standardized test, and how to give it so that it is given properly.
And you advise even experienced testers reread the manual from time to time before giving a test.
Yes, I think that sometimes if you don't use something a lot, or as you, or over time you find you're sort of deviating, it's helpful to go back and review the manual.
And scoring must be done according to the manual, correct?
Scoring must be done, if you wish to use it for the purposes it was designed, then scoring must be done according to the manual.
An important issue is whether a test has validity and reliability for the particular application for which it's considered, correct?
Correct.
Now, for every test you select, it's important to have good normative data appropriate against which to compare a patient's performance.
Yes.
So a certain test that only has data supporting its use with adults wouldn't be appropriate for a 12-year-old, correct?
I can't say that universally is true, but I would be very cautious using tests developed for an adult with a 12-year-old, yes.
Actually, it's almost 1 o'clock. Let me talk to council about scheduling, if I could, please. Gentlemen, I talked to the lawyers so that I could get a sense of timing. And the timing I'm hearing from the lawyers that the evidence will either end tomorrow or Thursday morning. You should be prepared tomorrow, although I really don't think it's going to happen, to stay past 1 o'clock tomorrow. I don't think that's going to happen, but just be prepared in case. And the estimate is that the evidence will end tomorrow or Thursday morning. Don't discuss the case among yourselves or with anybody else. Don't do any independent investigation concerning the case. Avoid any information from any source other than in the courtroom. Juries are excused until 9 o'clock tomorrow morning.
All rise. Hear ye, hear ye, hear ye. All persons having anything further to do before the Honorable David Lowy, Justice of the Superior Court, now sitting at Salem, within and for this county of Essex at present, depart and give your attendance at this place Wednesday morning next at 9 a.m., to which time and place the sitting of this court is now adjourned. I believe it's-